talking about giving dextrose and oral glucose, glucose being the oral, dextrose being the vascular version. The only time that we're going to give glucose is to a patient who can protect their own airway and they can follow commands. If they cannot follow commands to put the glucose in their mouth and kind of swish it around in between their tongue and the floor of their mouth, or in between their cheek and their gums, they're not really the patient that you want to give this to, right? We don't want to cause some kind of choking or aspiration. And one of the things that a lot of people might get tripped up on is they see a can of Coke and maybe it's Coke Zero or something like that. There is just no sugar in that. The amount of sugar that's in a sugar-free drink is so low that the FDA still allows the manufacturer to put 0 calories on it, which means that that particular soft drink has less than a gram of sugar in the entire can, which is doing nothing for your patient. So while it might taste sweet to you, it's of no benefit to the patient who needs the sugar. Giving the IV dextrose, right, this is our D50. In our local system where we're at now, everybody is very much with the D10. D50 is still in practice in some cases, but the truth of the matter is that D10 is much softer on the body, and what they've found is that patients who are administered D50 tend to have wild swings in their blood glucose levels, where the hospital staff are chasing that with insulin and sugar, trying to get them to stabilize out. Some of these patients are getting an extended stay in the hospital, sometimes as much as a week, longer than they should be. And so what they found is if we just give them enough D10 that we can get them to be non-altered and get them to eat food, that is a much better avenue for us. You want to make sure that as you administer IV dextrose, know that that sugar is necrotic to tissue. Remember that the sugar is going to have water follow it to try to kind of turn it into a soluble, and then we're going to pull that water from the cell, which is going to cause the cell to die, and that causes the necrosis. So anytime that you're going to give IV dextrose, make sure that you have a patent line that is large enough to take the sugar. In regards to administering glucagon, glucagon is a wonderful drug in the system if you're allowed to give it. It needs to be reconstituted because it is a hormone, so it is packaged in a powdered form. So you will inject 1 cc of normal saline into the vial. You're going to gently roll the vial between your fingers to get it to reconstitute into a liquid. Pull that back up and then inject the hormone. It is only effective if the liver still has stores of glycogen to which that it can dump into the body. And one of the contraindications to glucagon is that you have to know that you're going to be able to get this patient either to the hospital rapidly, or you are going to have some kind of IV access if you cannot get them up and moving enough to where they can eat on their own. If there's not an immediate way to get sugar back into their body, you are going to give them the death sentence. It may be more beneficial or smarter to just sit on your hands and rapidly transport unless you absolutely know that you've got this one in the bag. We're generally going to treat for DKA if the blood glucose level is more than 250. The goals are to rehydrate the patient, right? Because they're already urinating off plenty of the water that they have, trying to rid the body of the excess sugar. And then with that, we're going to try to correct the patient's electrolyte acid-base abnormalities by thinning that back up with the normal saline, right? Which is 0.9% sodium chloride, which is going to get us back into that kind of homeostasis area if at all possible. We're going to maintain their airway and administer oxygen if they need it. Remember, the goal is not 100% oxygen saturation, it's 90 to 94, and then treat the patient's symptoms. We're never going to actually cure diabetes. We're just going to treat the signs and the symptoms and get them to where somebody else can kind of stabilize them. If you're dealing with HHS, you're going to follow the pathway for dehydration and altered mental status. Again, AEIU tips, we're going to give them some fluids and we're going to try to get their body kind of thinning that blood back out and keeping their kidneys working. You may have to complete an advanced airway, and in the realm of the AEMT, that's a supraglottic. If they are unresponsive and you don't know if they've got some kind of trauma, you should consider C-spine. Large bore IVs should be gained as soon as you can. And by large bore, we're not talking 14s. I'm not talking the Punisher, right? We're not trying to hurt people. But we want an 18 or better, and you may want one in each arm so that you can administer fluid as necessary to try to stabilize your patient. All right, so now we're going to dive into hematologic emergencies, and hematology is the study of blood, and this is really more of a study in which the way the constituent parts of blood are involved with health and disease. So there are several components to blood, which is red blood cells, white blood cells, platelets and proteins, and then the last one I'm not even going to try to say today because I'm just having one of those I can't speak Latin days. Hematopoietic system. You guys can call me out on that in class if you want. That's the best I got for you. Hematologic disorders refer to any disorder of the blood. Hemolytic refers to the disease processes that cause the breakdown of red blood cells. Hemostatic disorders refer to bleeding and clotting abnormalities. If you remember in one of the previous lectures, I told you there's 12 clotting factors to the clotting cascade. It's quite complex to produce a clot. And if you're just missing one of these or there's a mutation to one of them, the ability to clot is significantly reduced. Blood and plasma, the functions of blood are for the respiratory function, right? And that's gas exchange. Nutritional movement, which is sugar and the waste products, the waste products of metabolism. Excretory, this is how we're transporting those things to the excretory organs, or the regulatory and defensive functions. So when we're getting into the finer components of blood, we're talking about plasma. That's a straw-colored fluid. It's something that if you see that kind of weeping fluid that comes out of perhaps like an abrasion, that's blood plasma or interstitial fluid. Red blood cells is what gives blood the typical red color, obviously. And you may have heard me say it before, but the cause for the red blood cells to actually give off that color is because of the iron being carried on it, becoming oxidized and what we would call otherwise rusting, which gives blood that telltale kind of brick red color. White blood cells protect the body against foreign invaders. They will kill aberrant cells that are within the body, produced by the body, or they will actually seek out and destroy bacteria and virus if they're able to. And then we have platelets, which is another component that is carrying oxygen in the bloodstream. Blood is formed primarily in the bone marrow. It is in most of the long bones, there is a marrowous space with a lot of vasculature around it, and this is where the blood cells are kind of coming from. The liver is producing a lot of the clotting factors and does a lot of the filtering, and then the spleen will filter and then will break down red blood cells and then help to produce white blood cells to kind of put back out into the bloodstream. When we're talking about blood, we should all understand the different types of blood, and so you have basically red blood cell classifications, which are O, A, and B, and then AB, and then that's Rh positive or Rh negative. Rh, I should say, O negative is the universal donor. Anything that is Rh positive can only be given to another positive Rh blood type. Anything that's negative in O can be given to all the different blood types. A's can only give to A's, B's can only give to B's, AB's can give to either A's or B's, but O's can only take O's. Transfusion reactions happen when there are different blood types from the patient's, his or her own, and that's a natural reaction. That's a foreign body invader according to the body, and so what ultimately ends up happening is basically a rejection. This is much like a transplant from a donor of an organ. If they are not the same blood type, the body immediately tries to reject that. And even if it is the correct blood type and it's a close enough genetic match, that particular patient is going to be on anti-rejection medications, which is an immunosuppressive, to keep them from rejecting the organ. The body is very adept at figuring out that a cell is not its own and will mount a response to try to kill off all of those cells that are not recognized as its own. Sickle cell disease is the most common inherited blood disorder. It starts with a genetic defect of the hemoglobin, and sickle cell crisis will manifest in several ways. There's a vaso-occlusive crisis, acute chest syndrome, or a plastic crisis, hemolytic crisis, or splenic sequestration crisis. And really what's happening here is in sickle cell disease, instead of the kind of donut-shaped cell, you have something that's kind of got a curve or an arc, and these red blood cells tend to kind of hook each other, and they will produce microclots. These particular patients will often start to build these clots up through the capillaries, which causes necrotic tissue, and it can generally spin out of control in a real fast manner. Here you can see kind of a picture of that. You've got that donut kind of shaped normal red blood cell, and then as you look at the sickle cell, you can see that kind of arc to it. It's got jagged lines to it. And again, this makes that red blood cell not very slippery. It's going to snag on whatever it can snag. They tend to stick together and clump. In an acute crisis, the patients have a substantial pain resulting from those congested vessels. So remember, like I said, this generally starts in a capillary bed, and as the capillaries are kind of entangled with this induced clot, so to speak, right? If you think back to the patients with a diabetic emergency, they end up with neuropathy. These patients have an acute neuropathy. Their distal extremities, or wherever this particular event is happening, is going to become hypoxic, and it's going to send out a distress and inflammatory response signal, and the patient's going to feel pain. So patients with chronic sickle cell attacks are vulnerable to severe life-threatening complications because they are shown to be more prone to produce these clots. Some of those would be PEs as well as stroke. So these are the potential complications. Again, that cerebral vascular attack or stroke, gallstones, jaundice, and this is because we're unable to actually filter the blood, and the liver is non-functioning. And I'm not going to get into all of these. You guys can see that there is quite a bit here. Leg ulcers is because any kind of real damage to the tissue is not getting good perfusion, and so the body tends not to heal very well. Retinopathy is where the retinas start to kind of degrade. They may detach. They can have the chronic pain from the neuropathy. Pulmonary hypertension, again, because we're creating resistance in blood flow, and then that chronic renal failure because of the reduced blood flow through the kidneys. Anemia is defined as hemoglobin or red blood cell levels lower than normal. It can be due to an autoimmune disorder. Red blood cells are destroyed by the body's own antibodies. Remember, like we were saying, the white blood cells are the hunter-killers of the body, and they can be programmed to basically kill anything that they want. And in autoimmune disorders, the body's antibodies are literally chasing down its own cells because it recognizes them as a threat instead of something that's normal. This is almost like anaphylaxis in a consistent basis, where the anaphylaxis kind of effect is coming from the intrinsic cellular bodies, and the patients will feel worn down, or they have really no energy, and that's because they're consistently in this state of attack where they almost feel like it's like flu-like symptoms, and it's really one of those things that's not well understood, and we don't know why this happens. We just know that the end result is that if there's not an immunosuppressant given for this, the body will quite literally try to destroy itself. Moving forward into clotting disorders, a thrombosis is a blood clot in an arterial or venous blood vessel. And then just remember that if we have something that's in the venous side, it's going to become a PE if it travels its way into the heart and makes its way into the lungs. If it's in the arterial side, it can become a stroke or some kind of occlusion in a distal extremity if it makes it that far down. Many of these things can be very painful or life-threatening depending on where this particular clot kind of makes its way into the body. So risk factors for that thrombosis are recent surgeries, impaired mobility, congestive heart failure or cancer, respiratory failure, infectious diseases, anyone older than the age of 40, being overweight, smoking, or oral contraceptive use. Even farther into the clotting disorders, we're going to talk about hemophilia. This is a clotting does not occur at all or occur insufficiently. This results in an increased bleeding time. It can be hemophilia A or hemophilia B. The signs and symptoms of this are the same. You're not going to be able to figure this out in the field. Disseminated intravascular coagulation. This can be as a result of any number of life-threatening conditions, and it progresses in a couple of stages. Identifying the signs and symptoms associated with it, or the progression towards this coagulopathy. In regards to this disseminated intravascular coagulation, the bigger problem here is that the body will start to produce clots inside the vessels, and what ultimately ends up happening is that the clots that are being developed actually take up all of the clotting factors inside the bloodstream. And so if there's any other injury or kind of pathway where there needs to be clotting factors, the body is no longer able to clot and they can bleed into full exsanguination. So that's it for this particular lecture. Hopefully this gives you a little bit of insight to hematology and some of the endocrine emergencies. In regards to any of the bleeding, remember when we get into any kind of traumatic or bleeds, it's CAB, which is stop the bleed. We want to get the circulation under control. In patients who have bleeding issues where they are unable to clot, right? This is a significant problem. And in our patients with the sickle cell problems, these patients are going to be non-perfusing. They can have that life-threatening emergency as well, and try to maintain a higher oxygen saturation in that patient. And in any case, all of these patients, regardless of whether or not it's an endocrine or a hematologic emergency, need to be rapidly transported to the definitive facility. As always, you guys can email me questions or we can talk about it more in class. Just do let me know if there's any questions that are not exactly clear for you, and we'll kind of expand into some of the discussion here and see if we can get you on the right path.